Hey, welcome, API members, to this first CME of this year. I'm Amit Chakravarti, your president this year, and I'm glad that to get started. I've taken over officially as the president on second, but still the gavel has to be transferred over during the convention, and Satish will do that. So he's actually busy with his convention coming up. I hope all of you guys attend that and make it a success. We've got a very exciting year with a lot of CMEs. I'm planning to give about 50 CMEs this year. Now, this includes cruises, governing body, and everything else. But bottom line is that if you are an RP member, you'll get 50 CMEs. Now, that I'm actually, this is only going to be RP members. And that's the only difference between RP and non-RP members, that our non-RP members can attend, but they'll not get CME credits because of the same simple reason. There are a lot of other things which we are going to do to try to boost up membership and interest, but that's a different day altogether. But today we're going to start with a CME. We are planning to do one CME a year. With each CME will have two hours,
A month.
and each CME will be one CME of 2 hours. So you'll get two CME hours every month, and you will have Tarak Vasavada, who is the CME chair, who is here, and Atul Prakash, the CME vice chair. Tarak is a psychiatrist in Huntsville, long-term friend of mine, and very astute and very detail-oriented person. I cannot find a better person who could be your CAV chair than him. Atul Prakash is a cardiologist and in the New York, New Jersey area, and he's also very much interested in academics and stuff like that. So we are the format again will be the same like we did before. Tarak will take over. He'll introduce his panel of speakers, and each speakers will speak, and then he can decide whether to do the question and answer soon after or at the end. Usually, that's up to the CME chair. Question and answers, and he can announce that, but because he's new, the first time he's doing it, so I'm just going to give you a little heads up that question and answer, put it on a chat box, and it'll all get stored, and he will, when the question and answer session comes up, he'll read it up from there. And frequently, sometimes what happens, we run over time and question and answer is still available. So what we do is we stop the CME, but those question and answers will be answered privately by the person who you have asked those questions to, and they can actually address it directly to the person, because the chat box will be open even after this is. This meeting is being recorded, and every CME will be posted on the API website. So if you missed the CME for some reason, you can listen to it. But getting a CME from there is a debatable question. I'm trying to see if we can do something to authenticate that, and people can get CME. But that would involve having question and answer at the end, because that's the only way to ratify whether you are attended or not. So having said that, today's talk is, which is near and dear to Tarak. I knew that he would start with this. He'll start with some mental health project, and I know that that is what was coming when I first nominated or requested Tarak to be the CAV chair. And also we have got great two top openers like Shubman Gill and Jaiswal today to start the batting for our CME, and Dr. Baweja and Dr. Gokarkanda, great friends of mine, and they will be excellent, I'm sure. And please pardon my being not dressed in a tie and all, because just came from the OR. So over to you, Tarak. All the best,
Thank you, Amit.
and let's get going. Okay.
Okay, thank you. I'm going to
I'll
share
I'll
my,
mute I'll mute
yeah.
myself.
Okay, let me share my slides. Let me go from there. Okay. Are we on, Srini?
Yep.
And Raman?
Good.
Yeah.
Good.
Okay.
Yes.
So, hello, fellows. Thank you for joining. This is the first CME under Amit, which is, as he announced, we'll be doing one CME events every month. and there'll be 2 CMEs total. So we may do around 10 months or so, because there are some months, the holidays and other things happening. So we like to give 20 CMEs plus other places. So if you keep on joining here, you will get the CME. You should become a member of API if you are not. It's very cheap. Still, I believe it's $100. So it's not difficult to join. So with this, I'll start the CME activities. If you have any questions, you can always reach out to me, or Vijaya can bounce the questions to me, or some of you have probably Amit's number too, and he can bounce the information or anything. I would also like you to keep in mind, if you have any great speakers, great topics, please, pass it to me, and our committee will look at it. So I don't have any disclosure. I work for.
Before you go ahead, just one pleased to say that Vijaya has joined.
Great.
So that'll be great. And number 2 is that the questions will be in the chat box, so you'll have to read it from the chat box, not
Sure.
directly to you or me or Vijaya. Just
Got it. I
FYI.
think I saw the chat box. So it should
Yeah. Good. Okay. Sounds good. Go ahead. Sorry.
Okay, so I'm starting this first CME session with state of pediatric mental health issues in USA. We have 2 astute, psychiatrists here, a child psychiatrist, and they see it more often than I do. You guys, some of you work in a hospital setting. Some of you are family members who are struggling to find, pediatric mental health help. And so we thought this may be the great thing. What can be better topic than taking care of our children? And that's like, 50-70% of us who are here are always thinking about that issue, why we came to this country for betterment of our family. I work for UAB at Huntsville campus. I'm a professor of psychiatry, and I was a past president of IAPA. And I'm also, like Amit said, chair of the CME committee. I do not have any disclosure. I'm a father and grandfather, so at least I can say some experience. So who are we? We are 4.7 million in the USA, according to 2020 census. We are number 2 minority, and who knows, maybe we should be number 1 pretty soon. We are highly educated, successful minority. We bring strong cultural and religious values with them, and sometimes it helps our children, sometimes it hurts our children. And we know ourselves at FOB, ABCD, coconuts, etc. Those are the kind of derogatory terms, but that's what we think in our mind. You are either becoming, you became a citizen, you are a green card holder, you are awaiting green card, born in USA, or undocumented, but likely not here. More likely to be married. We are more likely to be married as Asian Indians. That's, I think, the right term nowadays that we use. Less likely to be poor or divorced in our marriage. Maintain both Indian and American traditions, which is great, but sometimes it creates conflict too. So education attainment of Indian population, highly educated, US born, foreign born, it really doesn't matter. 75% of us have college education versus all Asians, which is 54, and all Americans, 33% have college education. So as you can say, we are highly educated. Key things to remember, few things you can take it with you, is that half of all the mental health disorders show first sign before a person turns 14 years old. And 75% of them show before the age 24. So imagine that. I mean, if you are more than 25 years of age in this lecture, you are lucky to be on 25% profile at this point. Only half of the children and adolescents with diagnosable are receiving any kind of help. So again, it is a prevalent issue that happens in a younger person. Lifelong illnesses happens. This is not a short-term illness where you recover and you are done with it. These are lifelong illnesses that happens to them. And 70% of counties have no child psychiatrist. So if you live in Alabama or like Srinivas live in Arkansas, it's very hard to find child psychiatrists in the smaller counties in our states. Or there's nobody there, I would say. I can't think of some of my counties nearby has no child psychiatrist. There is so COVID has caused havoc, and it has caused us to have so many visits to the ER. Our ER is full of these children, suffering. So 1 in 6 US children has diagnosable mental health disorder. 40% of high schoolers feel persistently sad or hopeless. Suicide is the second leading cause of the death in age 10 to 14, and even higher, up to 25 probably. When the young person dies, I mean, it comes to me as being a psychiatrist, like, did this person die of suicide or accidents? You know, when you are like a 16 to 18 years of age, your likely cause of death would be one of those two: suicide, homicide, or accidents are the leading cause. Emergency department all over the place are overloaded, like our department is overloaded. There are some boarding issues, meaning the patient just wait for 2-3 days, and sometimes even 5-7 days before they go in. And they're cramped in a small ER, and ER numbers has gone up. Unfortunately, somehow the visit for the girls has increased in last few years. The pediatric, again, is severe workforce shortage, like I told you earlier. There are, 10,000 psychiatrists for 15 million youth in need, one psychiatrist per 1,500 affected children, and 14 children and adolescent psychiatrists per 100,000. So my town of probably 200,000 people probably has like 20,000 or 40,000 kids, and then we should have so many child psychiatrists, but likely not. I think we have practicing child psychiatrists maybe 4 or 5 or so. Again, it's a national emergency. There's declared Vivek Murthy talk about this as a public health crisis, and 1 in 17 globally has mental health disorders. It's not just USA phenomena. It is increasing everywhere. This is an interesting study. I'll talk and I'll quit after this soon. A Healthy Mind study is done for the college students, and this 2023 data, 44% of students who are going to college. So these are educated kids that are going to, make some great advances for our community. They report symptoms of depression. They have anxiety. They have considering suicide, 15% or so, and highest rate in 15 years for the survey recently, last 22 and 23 both. Every like 109 or so colleges participate, so this is well kind of thing. Severe depression, 20%, these are clinically depressed, 38% any depression, anxiety disorders. In general population, the depression prevalence is like 6 to 10% or so, but this is quite high. Anxiety disorders is high, eating disorders are high, suicidal ideations, non-suicidal self-injury like cutting themselves, burning themselves is also 1 in 4 experiences that. A lifetime diagnosis of any mental illness is 50%. And then again, they lose more than 6 days in a month when they have these symptoms. Almost 22% had that issue. And large number of face loneliness. If you, I never looked at it carefully. When I looked at the loneliness data, it's the highest number of people who feel lonely are not the oldest actually group. It's actually the younger group. Even though they are with people, they feel that way. And I'm going to quit it here, stop sharing. And I will ask Dr. Baweja to start sharing his slide while I talk about him. And we go from there. You sharing it, Raman? I'm not seeing any questions. If somebody wants to just like throw a question or say hi or something, I can see that. Okay, you ready, Raman?
Yep, I am. Can I start?
Okay. So Dr. Baweja is my dear friend. We know each other for last several years, working in IAPA, which is Indo-American Psychiatric Association. He's a professor of psychiatry and behavioral health at Public Health Sciences in a Penn State College of Medicine. He is also part of is the associate vice chair of the Department of Child Psychiatry. He's also doing a lot for the development, for the faculty development, which I think is also important key issues for a lot of medical schools, burnout, etc. And then he is also part of the ACAP, which is the Child Psychiatry Association. He's well published, a lot of articles, and I probably won't go in detail for Dr. Baweja's accomplishment. And always proud of him presenting at American Psychiatric Association. and has several presentations. And it's great to hear him here. He's going to talk about pediatric mental health crisis and what clinicians and parents need to know. So we made this CME on purpose that even if you are not a pediatrician, if you're not just a general, family medical doctor, you can still learn here, and that's our goal. So come on, Raman.
Thank you, Dr. Vasadwa. And thank you for having me here. So today I will be talking about pediatric mental health in crisis, what clinician needs to know, but I also want to cover that what parents need to know, because knowing that one will help them when we see our patient and the parents are coming to us with the like different presentation. So knowing, understanding what parents needs to know about this crisis is also equally important. So I will be covering from identifying to supporting kids in need. So here is my disclosure, which has nothing to do with this presentation. I am just part of the different board member for the ADHD group, and I get travel support from the American Board of Psychiatry and Neurology. And I have done some consulting work, advisory board, and I have the research grant from the Cardinal Health Foundation for the zero suicide in our system. And I get that honorarium to participate in the ACAP, our national organization for the child psychiatry. So I have divided this talk into the four objective, but I will be covering the last two objective together. So I'm going to coming back to this objective again. So the first I will be talking about the common mental health concern among children and adolescent. So just before getting into this one, just as 30 to 45 minutes, 50 minutes presentation, I will not be going into the each and every diagnosis which we see in the child psychiatry, which is beyond the scope of this presentation. I will just want to give you overview, what's happening in the child mental health and what we can do, what symptoms we should be looking into that one. So Dr. Vaswadva already presented this data. So 50% of us will have some mental health disorder at some point of time in our lifetime. Nobody is immune. We have, after COVID, we knew about that it's impacting everyone, including us. We are not immune, and our family member, we all have gone through this difficult time. But our future, our children, 1 in 5 children, either currently or at some point of time during their lifetime, they have the serious debilitating mental illness. It is very concerning. So the numbers, the prevalence wise, pretty high. I think the autism now it becoming a lot of discussion in the different arena about the number of the percentage of the autism is going high. Either there is some reason behind that. In addition to like every psychiatric disorders are over the time getting more and more, but the recent abrupt change in the autism number is more likely is related to that we are able to identifying these children now. Earlier we even didn't know that one. Like I think many of us, depending upon when we graduated from the medical school, I think the autism, we were not even knew about that one. Even I was always wanted to be in the psychiatry, but just there was a one paragraph we read about that. But now, like either wherever you are practicing in the inpatient setting, outpatient setting, medical field, mental health field, you see children, adolescent, adult with the autism, and they have the different need, communication challenges than others. The other winner we have here is the ADHD. There is also concern about that. We are diagnosing ADHD more in our children actually, and that's also data supported by that the literature. If you will look into that, the European country, we see that prevalence rate is 5 to 6% in children, even when we are using. But in here in the US, that percentage are 9.8 overall. Actually, the new data is showing up to 11% kids. Actually, 1 in every 9 patients, they are getting that kids are getting the ADHD. If you will look into the scope of this present problem, if you have one kid, like there is one like two kids, like 1 to 2 kids in every classroom of 20 kids, like you will find that they are having this symptom of ADHD. And then we have the depression and anxiety. I think we all are aware of that. Anxiety is very prevalent, and it's very common everywhere. And again, which Tarak already mentioned about the suicide, which is really, really a major concern. And we are doing horrible in the last 2 decades. Actually, it's not like the COVID pushed to the point like we are just everything is falling apart. Even the data shows that we were not doing good with that the mental health of our youth. There is a multiple reason why it is happening, which I'm going to cover some briefly. So just to give you an example of the depressive disorder, right? This is the criteria. I get it from the DSM-5. In addition to that, it's not just a sadness. I'm feeling sad because of I didn't do well in my school or in my test. I didn't do well in my like relationship, or like I just broke up with my boyfriend, girlfriend. I'm feeling sad. This is not the depressive disorder. Psychiatric disorder have cluster of the symptoms happening during the certain time frame. For example, in the depressive disorder, you need to have 2 weeks of symptoms. So that's considered as the clinical depression. So first four criteria: sad, depressed mood, irritability, loss of interest, pleasure, anhedonia, feeling of worthlessness, trouble thinking. So these are the many cognitive or the body symptoms see that. But look at the next four symptoms: sleep disturbances, change in appetite, tiredness and lack of energy, unexplained physical problem, back pain, headache. You can present with these symptoms with the depression or even in the anxiety, which I'm going to cover very soon. So there are cluster of physical manifestation of the depressive disorder, as well as that the cognitive symptom when you are having this idea of hopelessness, worthlessness, and the last, the death wish and suicidal thoughts. Those are pretty concerning symptoms are there. So if you will look into this symptom: depressed mood, irritability, anhedonia, which is loss of interest and pleasure. Look at that, the anxiety disorder. That is our problem with the current diagnostic criteria use, which we use for in our day-to-day practice, DSM-5. These are the cluster of the symptoms. They can be transdiagnostic. You can have the same sadness, irritability, part of the depressive disorder, or you can have the same with the anxiety or others. You can see that the same symptoms are also presenting in the anxiety disorder. But then you have like cluster of other symptoms which they help you to diagnose what disorder we are treating at this time. And so always consider like having the more information about the reason why we need to. Sometimes the medicines are the same. Like for example, serotonergic reuptake inhibitor, we use SSRI for the depression and anxiety, but it's help you to what kind of therapy, what kind of treatment, how long you need the treatment, what other things, your resources you need that one. So diagnostic clarification is very helpful. Our youth, when we ask them as the parents and the grandparents, many times we hear the parents said, I'm fine, all right, how was your day? And they said, all is well. And sadly, all is not always well. We are struggling there. Our kids are getting this suicide. And this is the Indian data is coming from that, how that the academic pressure turning into that Indian community back in India into this suicide. But it's here. Like I work in the consult services, in the emergency setting. Like kids are coming from each and every level. Either like, it's not that the certain sociodemographic profile fit that criteria. They are coming from the every sociodemic profile, the parents, like they're there. So just briefly want to discuss that, which we are talking. I think Dr. Tarak also mentioned that one. So everything was going in the downhill course for the last 2 decades in the child mental health wise. And now what happened over the pandemic? It again further pushed that one. This paper is our paper is under review, which we reviewed that the 9 million plus patient from the United States and looking for what's happening in their mental health. In the depression wise, depression was worsening, anxiety was worsening, obsessive compulsive disorders were worsening, sleep disorder was worsening. If you will look into that, and what happened to their medication prescription, if you will look into that, anything on the right side of this line, the one relative risk, you will see that the sleep meds has gone way too far. Psychotherapies also get better, but antidepressant, antipsychotic, and overall psychotropic medications are keep going more and more. We are prescribing more and more. There are multiple reasons why it is happening. Access to, like, one of the things is that the mental health is struggling at this time. And then we look into that, okay, we divided this group into 3 groups. One are the preschooler, 3 to 5. I wanted to see either it is affecting the younger kids, then schooler, middle school, like elementary and middle school between age 5 to 12. And then we divided into the 13 plus, like adolescent there. So what we noticed that this is impacting mainly to our adolescent girl actually. And even in this is the data is from the adolescent. And how you look into that, when the blue dots, you will see either they are staying the stable or on the lower side, just except for sleep meds. But when you see the red dots, they are all are adolescent female. They are struggling the most with this whole COVID pandemic. And like I think Dr. Tarak also mentioned that the girls are coming with the more self-harm behavior. So pandemic also pushed our teenager, and it is also affecting a different pandemic has affected different age group and the different gender wise. So that's the we are struggling there. So the next I will talk about that what is happening, the healthy lifestyle and the youth mental health. Again, I'm not going to present too much data here, except for the one topic I would like to go in detail. So we all know that the exercise is good for you. Like COVID time, when we were working remotely, we were sitting in the same room, not interacting with us. So people shared like with each other, exercise, going outside, helping you for your improving mood, it helping your sleep, cognition, it's help you with almost everything. It's also reduce risk for depression or anxiety. Just looking for the data, like in the child psychiatry, you will see that the ADHD is considered the more biological oriented, like dopaminergic system is like you have a lot of study in there. Even in the ADHD symptom, where we have the most effective treatment for overall in the psychiatry with the effect size with the CNS stimulant somewhere between 0.8 to 0.9, even there, if you do the exercise, it does help you with the executive functioning as well as the core symptom. And again, there is a data to support its help in everywhere in the child psychiatry there. Similarly, like the food, like our youth struggle with the food, their eating habit and everything. Are they getting enough food or they're getting enough healthy diet? And if you don't eat the healthy diet, like you are starving, you feel tired, low mood or irritability, feel more stressed, inability to sleep, as well as the neurotransmitter depletion. Many of you have seen the patient with the eating disorder. They anorexia nervosa is there, but that's lead to more depression and more severity. But if you will look into that, these symptoms are also present in the depression or anxiety there. So it's important. So one thing is that which is protect us if they are part of the spirituality or religiosity. That is a multiple data is there to support that. It help you to connectedness with the other. And sleep, one of the reason, if you remember slide I showed you what happened during the pandemic with the medication wise, one of the worst medication which has gone up to 60% relatively to the pre-pandemic was the sleep medicine. So sleep has been disturbed during the COVID time, either with the virtual schooling, they have the more flexibility when they were getting up, but enough good sleep is always good for the well-being. And it has shown how that if you have the poor sleep, it impact everything in your life. You have the more likely to have the accident, you have more likely to have the impaired memory, you have that people eat more when they are not sleeping properly, and they increase their risk for medical condition, heart attack, or like, sorry, high blood pressure on the chronic term if you have the sleep difficulties, and reduce immune system functioning. And the what next is affecting our teenager nowadays with the sleep wise, social media. How many, like all of the kids have the phone nowadays, and one of the many thing when I see the girls in the coming to like I have heard this story multiple times. There was texting someone, and then how it's lead to them feeling bad because all of her friends cut them off on the social media, and then it's affect this one. So the one thing I would like to go, which is the new things which has affected, I think you all are aware of that, the social media. I think that is the one of the major forcing, one of the risk factor we see nowadays in that in our youth actually. So social media and mental health, its impact overall well-being. They have the high risk for the depression or anxiety, who they have the suicidal thoughts and self-harm. That's all our has been established risk factor with the social media and mental health there. But the social media, as a parents, as a clinician, which we are not aware of about the social media impact is, it is ongoing cyberbullying. Like, traditionally, kids will go to the school, then they have the break over the weekend, over the nighttime. They were not facing this bullying like when they were out of the school. So there was some break, but now this cyberbullying is going constantly round the clock, day, night, every time. And there is also social comparison. Like, if they put something on the TikTok, how many likes I get it. People obsessively check that one, or they are also they are impacting their sleep disturbances there. And again, what help them when they are using the social media? If they have the strong parental relationship and monitoring, significantly reduce the risk of the mental health problem among teens who are using the social media there. So it is tricky. If I would ask you, okay, how many like no, nobody should use the social media. I think in the current time frame, how practical it is. Like we all have either on the LinkedIn or the Twitter or like X or Facebook, we all the time. So it also helped to have to some connectedness there. But at the same time, we have the social mental health risk. If you are how you are using this social media is also impacting that. So it is the balance between the social connectedness, how much you want it, but at the same time, the mental health risk. And the next question is like that, how much social media do you have any evidence to support social media is like half an hour is enough, like 3 hours, 6 hours. And this study published, they mentioned that the more than 3 hours per day is definitely associated with the more mental health problem, particularly internalizing disorder, which is considered depression, anxiety. They are the more using this one. And the just recent study published in Pediatrics, it is not only about that how much time you spend. So if you look at the first graph, the time is definitely the more you time on the social media, the more likely to have the internalizing symptoms like depression or anxiety. But it's also engagement. It's not like you are just seeing this something. You just saw that in news or like it is more when you are responding to the other masses, texting, or like you are putting the videos how and then they're looking the comments and responding to the comments. That's really have the more association with their depression there. So the last part of this my talk, I will be more talking about the protective risk factor that influence mental health in youth, as well as resources and strategies to help support youth with the mental health. So I will be going at the same time because we have some protective factor, and then we're going to talk about what we can do there. So mental health it's a very complex, like physical health is very complex. You like, for example, if someone have a cardiovascular like MI, and then they have the risk factor, including their blood pressure, their blood sugar, high blood sugar level, exercise, their lifestyle modification. It's the same way, like, in the mental health of the youth as well. But here we also have some cultural factor, like how we identified the disease. It's not as simple as we say that your blood pressure is considered 120/80. More than that, you have the high blood pressure. But here, the cultural expectation, even we have the cultural bound syndrome as well. But again, culture play a role. I'm going to come that. And then the individual's variability, how your personality traits are, how do you interact with the world, what you see, and your coping skills. And there's generational, which is also coming with the biological aspect of there. Like, the more risk factor you have it, the more family history, the more likely to have that uh, for the mental health there. But then we have some protective factor and there's some risk factor. And these are the barrier or challenge which working hand by hand, and that's lead to that if someone have the depressive symptom or if someone have the depressive disorder, how it's overall present on the long term, that's the other thing with there. So Asian Indian community, I think we have very a lot of cultural factor which play with that. When we are coming from the rich cultural heritage, parenting practice are deeply influenced by our tradition, family values, social norms. We talk with the family. Many of us, we talk with our family member in India, back in India all the time. So our kids see them, they see that we are well connected, and that's helped them to connected with each other. Emotional bonding, we are good with that, expressing love, care, and affection towards our kids, giving them sense of belonging, being there for them when they needed that one. So we are, like Tarak mentioned, we are highly educated, we are highly successful, we are very strong people, we are coming them. So we have, like the generation we have it here, there are traditional values, emphasis on the resilience, adaptability, coping skills, and we help them, our children, when they are in that having the struggle there. And the spirituality is like practicing yoga, meditation, mindfulness, which is a part of our culture. Again, first generation American Indians, they are have the different one, and now how is going to imply on the second generation, third generation, things are getting more and more like acculturation happen, and then things get better. Here we are in the good shape there, but then we have some unspoken barriers which are more prevalent in our community, our group of the people. Stigma. Parents may hesitate to acknowledge or even discuss the mental health issue due to fear of the judgment and the societal shame. They have the expectation we are should be leading this one. We are getting into more successful, like mental health is for the weak and the stuff. And the denial. Parents may show downplay their child's struggle. Says, oh, it's the phase. It will pass away. It's a depression. So that's we see more in the uh, cultural situation we see there, like immigrant family coming from the India or other places, you will see the more this there. We also focus more on the physical health need than overlooking the emotional well-being. If someone say that I'm having headache, stomach ache, we get more attention, more not more attention, we are more attuned to pay attention there. But at the same time, when we are talking that I'm not feeling well, I think something not doing well, I'm feeling sad, we said, what do you mean by the sadness? Just move on or something like that, be strong. So again, the one thing I mentioned about that, the cultural thing, when we were talking about the depression and anxiety symptoms, we see them like it's part of the physical symptoms. Sometimes those symptoms are overlooked to look into the more like emotional health side. They are just more into, so very it's common, like even in India in here, like for the first concern, if you're not talking with your child, they are coming with that, the belly ache, stomach ache, school avoidance, that of the symptoms. And when you spend time with them, then you realize, okay, it is under the surface, there is a lot of psychosocial psychological stuff is going on there. Family honor. Some parents may prioritize maintaining family honor and avoid acknowledging mental health struggle or seeking professional help in the children, believing it reflect poor on the family unit. So yes, so we see them, not don't talk about this one. And I don't want to have any schools like we have seen some parents coming from Southeast Asia, they want to not to have the school accommodation because everyone know about they have the mental health. I said, but your child need that one. This is going to be the helpful. Many families, they are not aware of that, like about the mental health condition symptoms, what are the available resources are, and they may be using the more different term, which may not be the wording which we use in the Western culture. For example, they will be using the nervousness, tension, which may be not diagnosing in place of saying I'm feeling anxious or worries about the things there. We also have a lot of pressure to excel in our community, that we have the high emphasis on the academic achievement. It's not only for the Indian community, it's also for the Asian community, very like overall Asian community, if you're looking into that, including from the China and there. So it is sometimes child feels a lot of pressure because everything is being compared, and they are a lot of pressure they from have their parent expectation. It is expected them to be keep exceeding there. There is, I don't know if you have heard about the model minority myth. I'm going to read about that one. So just to, it is so, when I read first time about this one, this is from the Sarika Rao. I look into that, the ADHD attitude. This is the one magazine on the ADHD. If I was not being shamed by my parents for my grades or apparent laziness, I was being judged at school for my weight. I felt as thought I was a waste of the incalculable time and money my first generation immigrant parents put into raising me. I felt unworthy and worthless. So these are the pressure which minority youth or that over Indian community youth, they feel intense pressure on that one about the academic achievement or academic exceeding. So school stress versus the achievement, we need to have this discussion with the family. I have heard many story, straight A student, Victorian from the high school, and then they just go to the one of the Ivy League school, and they really crashed there. They couldn't handle that, the stress there. So again, this is the balance. Like So having this discussion with the parents or the child, yes, I want to go there, and then they are struggling with the three APs and everything, and then they are presenting with that the mental health crisis and everything. Oh, I have my home. Then have the discussion. Okay, like how much you can handle that when everyone have their certain limit, beyond that they crash there. So just to bring some of the ADHD in Asian community, there are actually not many literature on the Asian Indian. If you will look into that, there are only a couple of papers I could find in that one. So as expected, they have the challenges in recognizing and addressing ADHD. They just consider their ADHD symptoms are part of their laziness or not living up to the expectation. And that's lead to their delay in treatment as well as treatment contact with the ADHD provider. And the same with the autism, actually. They have the delayed recognition. So this study was actually done in rural part of the Goa, but then they compare the prescript, like how the diagnosis in the autism community in the Indian setting versus what would happen in the in what they're understanding about the autism there. They have the lot of like influenced by the cultural norm. There is a delay for 6 to 8, 10 months of diagnosis of the diagnosis of the autism. They have a lot of ex explanation or interpretation, like either spirituality, moral, personal reason, and they actually go to the divine intervention or perform ritual to address it before actually they got assessment and treatment there. And they have the 4 phase of the treatment there. The early life, they feel that everything is good, normal, nothing changed there. Then they see that their child behavior is start disrupting their social order, but parents feel that it is temporary, it will get away. And then in the phase 3, they have the parent perceive as a persistent problem and then interfering with the child activity. And then at the last phase, actually they accommodate their child's ability to reshape their real social world. I have seen many family in the US, as well as some of them, they are Asian Indian family who are just they change there where they go for that one. Do they go to the temple? They go to that their Gurdwara because of they stop doing this one or they stop doing that activity because of the diagnosis is there. So they don't recognize symptom. They have the different explanation. So it is not surprisingly this community have the more likely in the delay in the treatment. They are labeled as a, if they have the ADHD kids, they labeled as the notorious kid, like oppositional kids. And if they have like learning disability, then we know about this very good movie we have, Tare Zameen Par. There they have the how they have the learning disability can lead to the delay in the treatment and affecting this child there. So very often the parents' concerns are like it's just few of them. He just isolate themselves in the room, doesn't do much with the family, often challenge the boundaries, rule establishing. Child react defensively, saying that, "What do you know about what is going in the school?" Or "You never grew up here. How do you know?" And that is true actually. My schooling was in back in India, and I didn't know that what the IEP or like 504 program, and I started doing this one here as a professional, as a parents as well. When my child is looking for the AP courses, I have no idea what that mean and how I can find this one. And I'm concerned about the possibility of my child using drugs, which is our next presentation, and how I can have them maintain and like meaningful conversation here. So just how we can support the family and provided the strategies for the parents. One thing is educating them, like raising awareness about the mental health condition, their symptoms, their cluster of the symptoms, how it is affecting their functioning, as well as how they're affecting their overall well-being there. Having open communication, it's okay to talk about the emotion. It's make it normalize that like emotions are true, and everyone can have the mental health challenges like the way we have the physical health. And I openly talk about like how my dad get the like after MI, when he get the like never have any mental health, and in his 60s he got the anxiety disorder, and I started him on the Sertraline at that time, for example. It's okay to normalize these things. Things happen, and seeking professional help whenever you need it. Assisting parents to recognize when the professional intervention is necessary. Either we are seeing in our clinic or even in our family life or other places, and what are the community support system we have it in the there. More and more sports group are coming, but also remember that this Asian Indian, American Indian, not American Indian, the Asian Indian, they may not be really want to go into the group setting. So understanding what they're coming from and what their hesitation about can be also helpful there. And the last thing, we are also not aware about the school and mental health. which is really very stressful about the academic stress, as which I mentioned earlier, bullying, and there leads to the mental health concern. Having their guidance counselor accommodation, talk with them if their mental health is there and if they need any special accommodation for their mental health there. So how we treat the ADHD, like all the psychiatric disorder. And if you will look into that, center focuses the psychosocial treatment, which include therapy, like all the psychiatric medications, specifically about the ADHD, autism spectrum disorder, anxiety, depression. Anxiety, like psychotherapy is as effective as the medication, and plus medication have the side effect, and then the long-term basis they need to learn the coping skills. And second thing is that if they're struggling with their school, that could be the part of that. And whenever necessity are there, we have many FDA approved medication in the different classroom which we use for the different treatment, and it's all depend upon the how severity these symptoms are and where they are heading from there. And there are the crisis resources are there which we can always offer to the family. And now we have like 911, we have 988. The other thing which I didn't discuss about that, if the child is coming from the gender diverse background, they have the more high risk for that mental health. And this is also coming from the Asian Indian community. It can be even more challenging given that the acceptance there. So in summary, there is a cultural influence that we have the parenting practices, deeply rooted rich culture we are coming from, traditional we show our emotion. We want to be towards the with the family, with the patient, with our child. But at the same time, our community also struggle with the stigma and denial about having the mental health, and they may not be aware of their mental health conditions, symptoms, and resources. And how we can support them, need to have the open communication, encourage it about talking about their symptoms, what's going on, validating their emotion. Early recognition and timely intervention is very important. And there are community support as well as professional help when needed. We encourage family to talk about their mental health and get the services which they need that one. With this, I will end my talk and back to Tarak. Tarak, you there? Maybe Srinivasa, you can go next. Yes, I can see your slide.
Can you see my screen?
Yep, you're good to go.
I don't see the presentation mode here.
Yeah, it's in the presentation mode.
I'm going to use my. My name is Ashwini, also associated division director of child psychiatry. It's glad to be here with Dr. Vasavada and Dr. Baveja, who are psychiatrists and seniors to me. And today I'm going to talk about that has a lot of stigma. Dr. Baveja has mentioned about stigma in mental health. There is a lot of more stigma with substance abuse issues. And then we have Dr. Vasavada has mentioned about the number of psychiatrists in the country. I'm just giving you Arkansas perspective. There are about 70 child psychiatrists in the state, and there are 2 child psychiatrists that also does addictions. So the Six Bridges Clinic, which I'm the medical director, was the first clinic in Arkansas that provides substance abuse plus mental health issue care in the state of Arkansas. With that introduction, I will.
Srinivas. Hey, sorry, I somehow lost my co-host privilege, but I can introduce you. But if you're okay, that's fine. I think you're doing a good job.
I think Yeah, I think we're good, sir. Thank you. No
I'm
problem.
so sorry. Yeah.
No problem. Okay, I have no disclosures to disclose here. So today we'll be reviewing the epidemiology of substance abuse disorders, especially in teens and young adults. Also identifying the signs and symptoms of substance abuse, how to identify children that are using drugs. And also at the end, I know there are some pediatricians in this on this talk. And for the interest of the group, I'm going to talk about screening, brief and prevention, and referral to treatment, which is primarily designed for pediatric primary care offices. So what's substance abuse? Substance abuse is defined as the use of illicit, which is prescribed medications, illicit substances other than what is medically indicated, such as tobacco, alcohol, cannabis. We have amphetamines, cocaine, sleeping pills, hallucinogens like mushrooms, opioids, any intravenous drugs. All of them comprises of substances that can be abused. And in the US and across the world, the most commonly abused substances are the number one substance is tobacco, followed by alcohol, and marijuana, the third commonly abused drug across the world. So again, substance abuse does not discriminate between rich or poor, white or black, Asians. So it is a disease that is present across the communities, across rich and poor. So there is no discrimination. Addiction can affect anyone and everyone. So this is a busy slide, but I just want to show you what are the pathways in the brain that actually are the prime pathways for addictions. There are some areas of the brain that are more vulnerable for measuring effects, like dopamine is produced in a ventral tegmental area, and we have nucleus accumbens, we have prefrontal cortex, we have hippocampus, and amygdala. These are the 5 areas of the brain that are frequently involved in the process of addiction. So dopamine is a feel-good neurotransmitter that is produced when any pleasurable activity, eating food, hiking, biking, sex, any of these pleasurable activities can increase your dopamine levels in the brain that enhances your wanting to do that again and again, right? So that is the significance of dopamine in the brain. The 2 important pathways that are involved in addiction are mesolimbic pathway that is shown here, and then in the pink, and then the mesocortical pathway that is shown in blue or green here. So these are the 2 pathways that are commonly involved in the process of addiction in the brain. So what does drugs do to the brain, right? The drugs that are commonly used, like cocaine, meth, opioids, alcohol, all of them target the brain's motivation and reward system. So that these drugs will flood the nucleus accumbens and creating a feelings of pleasure and reward and wanting to do more. Over a period of time, this dopamine keep increasing in the brain, and then the brain, which is normally supposed to produce dopamine for simple pleasures like food, biking, any pleasurable activity, will stop producing dopamine. So that people that are abusing drugs will want to use more drugs to get the same effect from use of drugs. And then what drugs do in the brain, especially in a developing brain, they will disrupt the process of learning, process of judgment, decision making, and then how we respond to stress is also affected with the drugs. And then drugs also impact memory. They disrupt the connections and cause them to memory loss, cognitive issues, recall memory especially. And then drugs also cause withdrawals. We'll talk more about that in a minute. So the Diagnostic Statistical Manual, which is commonly used in psychiatry to actually offer diagnosis and also used for billing purposes, has categorized substance abuse into 11 symptoms. If a person has more than 2 symptoms, it is considered as mild substance abuse disorder. If it is more than 3 to 4, it's called moderate. And then any symptoms over 6, it's considered as severe substance abuse disorder. So they club these 11 symptoms into 4 different criteria, which is impaired control. So once you start using drugs, there's no control, they lose control, and they want to do more drugs because they have cravings, right? Desire to use more. And then also they try to stop using and they keep doing more drugs, even though they try because of cravings. Social problems. What kind of social problems? Failure to complete major tasks, especially at school, and if somebody is employed at work, and also restricted, activity in the community. If somebody is biking or hiking, they stop those activities and be more in the process of using drugs, obtaining drugs, things like that. And then dangerous use of drugs, unsafe settings, using alcohol while driving, using drugs while driving. And then, so these people, when people are addicted to drugs, they use those drugs despite knowing that it's affecting their life, despite knowing that they lose their job, despite knowing that they are failing grades, even with that, they keep doing it. And then finally, drug or a period of time after using drugs, it leads to tolerance, which is, they need more and more drugs to have the same effect, desired effect. So they keep increasing the amount of drugs over a period of time. So that is called tolerance. And then the final symptom here is the withdrawal symptoms. So when people use drugs and then they stop using them, they have this withdrawal because there is no dopamine in their brain, and then they need dopamine to function. So they wanted more drugs. So that is withdrawal cause anxiety, withdrawals cause sweating, withdrawals cause cravings. So then people use more drugs, right? Somebody who drinks alcohol overnight wakes up in the morning and they started having withdrawal symptoms. They needed that morning drink of alcohol so that the withdrawals have stopped. Right? That's the withdrawal symptoms. So out of these criteria, so 2 or more is considered as mild, 4 to 5 is considered moderate, and then above 6 is considered as severe substance abuse disorder. So what new? 1.5 this is according to the National Survey on Drug Use and Health. So that is about 4% of all children aged between 12 to 17 has a substance abuse disorder in 2020. And then the cost of substance abuse in this country, about $500 billion annually in cost. That is about $1,500 for all of us on this call. For every year, we are paying about $1,500 for substance abuse that was present across the country. So the costs include hospitalizations, costs include ED visits, costs include infectious diseases, unplanned pregnancies, accidents, homelessness, unemployment. All this combined will cost about $500 billion every year to the country. So why is teenage considered as a drug danger zone? Most people that use drugs as an adult have started substance abuse before the age of 18. If you look at this picture, I like this picture. This was published in 2012, but you can see that the age group between 12 to 13 have 3% substance abuse, and then 14 to 15, 8%. It keeps increasing over a period of time with the age, right? With 16 to 17, 11%. And as we go on to 21 plus, the substance abuse initiation rates go down. So people won't start new substances, using substances at that age or experiment substances. So this is the age group where there is less impaired judgment, right? Impulse control, poor impulse control issues, and then sensation seeking that increases the risk or vulnerability of youth to using substances. Like I said, this diagram on your right shows the development of brain between the ages of 5 to 20. The more blue on your right here on the prefrontal cortex or cortex here, that means there is more development. The brain is more developed, fully developed by the end of age 20. So on your left, you have a behavior, and then the fMRI activity of brain, which is depicted on the bottom. So, like I said in the previous slides, nucleus accumbens is the place where there's a lot of dopamine, which is a pleasure reward system that is releasing dopamine that is correlated with sensation seeking. Right? There's more sensation seeking, there is more dopamine release from nucleus accumbens. And then if you look at the picture here, there is children that are highly impulsive, and then we have teenagers that are impulsive, and then compared to adults. Again, the prefrontal cortex is fully developed in adults, so there is less impulsivity. And then if you look at the prefrontal cortex in the teenage, and then there is more impulsivity as well here. So those are the reasons why teenagers experiment drugs more in the preteen years. Sometimes, I've seen kids at 11, 10 abusing cigarettes, abusing marijuana that they get from their family, alcohol, cigarettes, right? All this is done through experimentation and sensation seeking. So like I said, the prefrontal cortex is not fully developed in teenage years. And then there is a high activity of striatum, which is the nucleus accumbens. If you look at the graph here on the left. So PFC is prefrontal cortex, striatum is the nucleus accumbens here. In children, it's not fully developed. In adolescents, you see there is more stronger development of striatum, which is the nucleus accumbens, which produces dopamine. And then the prefrontal cortex, there is a connection to the prefrontal cortex, but the prefrontal cortex is not connected well with the striatum. So prefrontal cortex is like a brakes to your car, and the striatum is a car full of gas, right? So there is car that is full of gas and no brakes. That leads to sensation seeking, that leads to drug use, impulsive behavior, and then problematic, sometimes, sexual behaviors. Everything happens because of poor judgment and impulse control issues. And then if you look at the last picture on the right here, the prefrontal cortex is fully developed in adults, and the striatum is fully developed, more mature. So the connections are fully developed. That means there is a gas pedal, there is a brake that is fully functional, so that the adults can, make a judgment, good judgment based on the situation they are in. Okay, with that, we'll just review. I know Dr. Baweja has reviewed some slides about the epidemiology of mental health issues, and even Dr. Vaswada has also reviewed some slides, but I'll go quickly on this part. But I just want to show you how bad the problem is in this country, and also I'll also review some slides from India, one of the recent studies that was done in India.
Srinivasa, your voice is breaking in between, and if you can stay with the near to the mic, that will be helpful. There are a couple of comments there on that. Okay.
Okay. Sorry about that. I don't know if it's the. Let me switch my microphone to the.
I think there is some echo there too, so that's what is happening.
Okay. Sorry about that. Let me see if I can.
Can you hear it any better now? Okay. Sorry about that.
It's very good. Better now.
Okay. So this is the report that is released every year by Wellbeing Trust. It's called Pain in the Nation. They look at the problem of alcohol, drugs, and suicide rates across the country, and then they run some statistics about what's going on in different age groups. And so this report has significant issues in this age group, which is 12 to 17 age group. There is an increase in hopelessness in high school students. There is also increased thoughts of suicide, about 22% in 2021. About 45% of the high schoolers feel they're hopeless and sad. And about 10% of them attempted suicide in the last decade. These trends are also similar in the Asian population. There is no specific Indian population, but these trends are almost similar with the Asian population, which is including Indians. In the past decade, there are about 1 million deaths from substance abuse, mental health issues, and suicides in total, which actually decreased the life expectancy in the US. I don't know the exact number now, but because of the overdose deaths and deaths due to alcohol and suicides, that has decreased the life expectancy in the US. So this, the previous slide looked at the alcohol, suicides, and mental health deaths due to mental health. But here, this slide talks about or depicts the overdose deaths from 1999 to 2023. The good news on this slide is if you look at the deaths from overdose in 2022 to 2023, there is a decline in the deaths in 2023. Actually, there is a preliminary data that was not published yet that actually showed further decline in the overdose deaths in 2024, partly because of the naloxone distribution across the country, free naloxone distribution across the country that has helped in reducing the number of deaths, overdose deaths. So this is a slide that is showing the drug overdose deaths by different age groups from ages 15 until 65 and older. This is again from the National Center for Health Statistics, published in 2024. If you look at the deaths in age 15 to 24, it is 15% in 2022 and 13% in 2024. Even though it's less, compare that with age 65 and older, we have a similar rates of overdose deaths in the age group. And if you see the 35 to 44, they have highest overdose deaths, which is 63% in 2022 and 60% in 2023. Even this 15 to 24 age group, that is really concerning because they're just started using drugs, they're experimenting drugs. And then one-time use of fentanyl can kill them, right? So that is accidental overdose from fentanyl or the newer drugs like xylazine. I'm going to talk about that in a minute. So this is really concerning, the overdose deaths in this age group. And looking at from the same data, looking at which groups are more vulnerable. Like I said earlier, it doesn't matter to addiction whether you're white, black, rich, poor, everyone is affected, right? But some communities are affected more than the other communities. If you look at this graph here, American Indians, Alaskan Natives are more affected with substance abuse compared with the Asians and the non-Hispanic Asian population. But the concern, I'm really concerned about the increase in trends in Asian American population because I've seen several kids that are in treatment, are actually seeking treatment for substance abuse. So but I think the trends are going up. If these trends continue, we will actually see similar trends with white and Hispanic populations in the near future. So what does it do? So if a parent dies from a substance abuse, if the parent goes to jail from substance abuse, if the parent divorces because of substance abuse, right? Then it affects the entire family. It affects the children in the family. If you look at this slide, more than 300,000 children lost their parent to substance abuse overdose, drug overdose in 2011 to 2021 in the last 10-year period. So these children have a lot of issues, like because they don't have a supportive family. That leads to more mental health issues like depression, anxiety, substance abuse, and also that is because of trauma that they have from a loss of a parent or no parent in their life. So this report is published in JAMA Psychiatry in 2024. This is a really concerning report. So with this, this is a study again done through a National Survey on Drug Abuse and Health, or Drug Use and Health, in teenage ages between 12 to 17, looking at if they looked at if tobacco use increases the risk of other substance use, if no tobacco use decreases the risk of substance abuse. So on your left, you see there is no past movement cigarette use. Right on your right, if somebody who is smoking cigarettes also smokes marijuana, also uses alcohol, also binge drinks, and use other illicit drugs, right? So people may, because of stigma, right, they might say like, this kid is just doing vaping cigarettes or vaping nicotine or doing cigarettes. It's just a cigarettes, right? So that cigarette use may lead to other drugs, may lead to marijuana, may lead to alcohol use. It won't stop with just the cigarettes, right? And then this next slide looked at people that use marijuana and people that don't use marijuana. So in the past month, if they use marijuana, look at the alcohol use of only 8%. If they use marijuana, the alcohol use went up by 44%. Same thing with the binge drinking, 3.5% with no marijuana use, and then 27% with marijuana use. And of course, cigarette use as well, 23% to 2% with no marijuana use. So one drug increases the risk of other drug use. And then finally, looking at the alcohol use and no alcohol use. When they use alcohol, there is increased risk of cigarette smoking, increased risk of marijuana smoking. It's all from the same study. So this is a study that is done every year. It's called Arkansas Prevention Needs Assessment Survey that is done in 2023. In all schools from 6th grade to 12th grade, they surveyed about 50,000 children in Arkansas, which is a small state, but this is a good sample. They surveyed about 50,000 children, and then they looked at the age at first cigarette use, first marijuana use, first alcohol use, and e-cigarette use, prescription drug use. Look at the average use of first use in 2018 to 2023. For cigarettes, 12.5, age 12.5 average. And then in 2023 is 12.2. So the age is going down. The younger they are using more drugs now compared with 2018. In 5 years, that changed. Look at the e-cigarette or vaping use from age 14 in 2018 or age 13 in 2023. They're using more sooner than 2018. Same with the prescription drug use. So more and more kids are experimenting or initiating drugs at a younger age than earlier, 5 years ago. And this is another concerning picture from the same study, from same survey. look at the amount of the girls that are experimenting drugs than the boys, right? And on your right, you see the girls that are more using more alcohol, more marijuana, more inhalants, more cocaine, prescription drugs, over-the-counter drugs, alcopops, which is sweetened alcohol, and CBD products, and of course, vaping marijuana. On the other hand, boys are more using cigarettes, smokeless tobacco, hallucinogens like mushrooms, ecstasy, and steroids. So there is a gender difference here. So the more and more girls are using drugs these days. So just be aware of this statistic, because if this is happening in Arkansas, this is happening across the US, right? So what do we know about substance abuse disorders in India? So the data on substance abuse in this age group, adolescents and teens and young adults in the US is very sparse. Like there's not much data compared with adults. So same with India. There are very few studies that were done prior to this study in India. This study was published in 2024, done in 2023 across the primary healthcare centers in India. Looking at the determinants of substance abuse, what are the risk factors for substance abuse in young people attending these primary care health centers? So this is a multi-center study that was done in 15 states. About 1,600 children or young people, 10 to 24, were screened in primary healthcare centers. They used a tool called ASSIST, which is alcohol, smoking, substance abuse involvement screening test. The prevalence was 32% or 33%. And then the mean our median age of initiation is 18 years. So the age of initiation here is about 12 to 13 years. The age of initiation in India is about 18 years based on this survey, right? So which may be accurate, which may not be accurate, but the more, so younger kids in the US are using drugs compared to India from this one study. 75% of these participants have started using drugs before the age of 18. And again, most commonly used drugs, substance is tobacco, followed by alcohol, and then we have cannabis after that. So being a male, high age, urban residents living in a city, a positive family history, staying in the northeastern states, and low socioeconomic status increases the risk of substance abuse. This is a summary of that study showing the methodology of the study, where it was done. The study was done by AIIMS Gorakhpur. And on your left, you see the outcomes, the drugs that were used by the survey sample. And then the determinants of substance abuse, which will be the higher age, male gender, and living in cities and family history. So the risk factors for substance abuse, I know Dr. Baweja has talked about risk factors for mental health. So there are similar risk factors, like, whatever the risk factors for mental health also play a role in the risk factor as a risk factor for substance abuse. A genetic predisposition, somebody who has a parent that has alcohol use disorder has more likelihood of using alcohol. About 40 to 60% of children with a parent of alcohol use disorder will use alcohol as they become adults. And they did some studies where a child was removed from the parent of alcohol use disorder and then was adopted into a different family. Still, that risk has persisted, used alcohol even though they were removed from the biological family. Same with the twin studies, twin concordant studies, basically high concordant states with identical twins. If somebody who's an identical twin has more risk than the fraternal twins that that are born to parents with alcohol use disorder. There are some genes that are predominantly predisposed to the risk of alcohol use disorder, called OPRM. There are a few genes, ADH1B, ADH2, and there are some protective genes that actually protect people from alcohol use disorders. So that's the genetic predisposition. The environmental factors, just like the mental health issues, the environmental factors can be clubbed into 4 different domains here. Community where they live in, right? The kind of community. Is it a poor neighborhood, rich neighborhood? A lot of crime in the community increases the risk of substance abuse. Drugs freely available in the community increases the risk of substance abuse. And also family. If there are drugs in the family, if there's alcohol always available in the house, that increases the risk of alcohol use. And same thing with the marijuana and tobacco as well. Schools, a lot of kids these days, if parents are strict, parents doesn't have anything at home, schools are the place where people are exchanging drugs these days. Parking lots, school parking lots have been the place for exchange of drugs, exchange of vaping pens, exchange of marijuana these days. And my clinic has so many patients that actually were withdrawn from school by the parents because of this reason. They don't want to send their kids to school because they're worried that these kids are doing drugs at their schools. And then finally, the individual and the individual factors. What are the individual factors? We looked at, Dr. Baveja has mentioned about trauma. If somebody has a parent that was, a substance abuser or has an overdose deaths or in jail or in prison, any kind of trauma increases the risk of substance abuse. And also gender issues. If somebody has gender issues, they don't know how to cope, right? That coping mechanism is lacking. So they rely on drugs to cope for those issues because they can't tell anyone because there's a lot of stigma and there's poor acceptance from the families. So that lead to substance abuse and also increase the risk of suicide attempts in people with gender issues. And finally, peer pressure. So this is one of the important factors or most important risk factors for substance abuse. Somebody who has a group of friends that are using drugs, they don't want to be left out of the group. They want to be part of the group. They want to be, in the group, right? So they are forced to use drugs. They're forced to do whatever the peers are doing. So peer pressure is one of the significant risk factors for substance abuse in youth. What are the warning signs? How can you tell if a child is doing drugs, right? This is a common question that we see all the time. There is a sudden change in behaviors, sleeping late, coming home late, right? If somebody who goes to swimming stops go to swimming, somebody who plays soccer stops going to soccer. Somebody who has a good academic standing in the classroom, you see a drop in grades. Drop in school attendance. These are some preliminary signs of substance abuse. And then you also see mood swings over a period of time, a lot of irritability, and then secrecy, isolating to their rooms and staying up late, right? Changes in sleeping habits, changes in eating habits, stop eating food, weight loss is another major warning sign. Talking about sleeping habits, I have a patient that started ordering dextromethorphan to his house. So mom thought the child has cough one night. And then the dextromethorphan came through DoorDash. So she thought it was a one-time thing. And then there's more DoorDashes coming in around midnight and 3 o'clock in the morning, because the child was using so much dextromethorphan during the day and they wanted more dextromethorphan because of the withdrawal symptoms, right? So that is a big warning sign if somebody is not sleeping. And then the physical signs, not taking care of themselves, poor hygiene, bloodshot eyes, smelling marijuana, right? Smelling marijuana is also another sign. So these are some warning signs to look out for, children using substances. So I'll just briefly go through what marijuana does, what alcohol does, and quickly, and then the screening
We may
tools.
have like a 5 minutes or so because we may be entering the question answer phase. So,
Sure.
but I think we can come back later on with your thing.
Okay.
Time permit. But go ahead.
So this is a slide that shows the percentage of THC in marijuana compared with the CBD. So THC is the most psychoactive compound of marijuana compared with the CBD, which is the less. It's not a psychoactive compound. That means more THC leads to more euphoria, more pleasurable feelings from marijuana use. If you look at the marijuana that was seized in 1995. That has about 14% higher ratio of THC compared with the CBD. If you look at 2022, it's 134 times. I have to use my calculator this morning to put that number. 134 times more potent marijuana these days. And that's why there are more and more kids are using it because of pleasurable effects of euphoria from the substance. And there are two types of THC, Delta 9 and Delta 8. Delta 9 is more psychoactive than Delta 8, but it's about 50 to 60% less potent than the Delta 9 marijuana. And then these days, marijuana is obtained through smoking, eating. You have vaping, and then also the dabbed waxes, which is the concentrated marijuana that is available in the form of waxes that is smoked by people. And look at the age groups on the left here. 12 to 17 has almost equivalent to age of 26 to 34 age group, the same levels of marijuana use in this age group between 12 to 17 and 18 to 25 has the more higher rates of marijuana use compared to other groups here. More males use marijuana than females. And again, this is a high potency marijuana, which is called DAB on the right here. And then you have CBD vapes, you have Alcopops. This is a more popular one now. Alcopops are used by more girls because it has a sweetened alcohol, 12% alcohol, high concentrated alcohol with sweetened beverage. So a lot of girls have started using this. And also boys, of course, but this is more commonly seen with girls. And vaping pens, of course, there are a lot of vape flavors that are attracting kids to use vapes. And in your right, you see that you can differentiate between the real pill and a fake pill. So any of these fake pills can go, can reach to our children, and that might contain fentanyl that can be lethal when they take it, right? Like I said earlier, marijuana causes euphoria. It can cause red eyes, dry mouth, difficulty concentrating, decreased coordination. These are all the signs, effects of marijuana. And it can also cause paranoia, which is the most common symptom that we see, and then all the other problems. Like I said, fentanyl is one of the strongest opioids that we have seen, and then xylazine is another one that is also used as an anesthetic in animals. A tranquilizer. It's called tranquilizer, and DEA has actually seized xylazine and fentanyl mixtures in about 48 states. In a remote state like Arkansas, we do testing for xylazine. We have a patient that tested positive for xylazine in the routine drug screens. What's significant about xylazine? It is not an opioid, so that means Narcan cannot reverse the overdose from xylazine. A patient that takes xylazine, overdose on it, there is no reversal. So that's why we have fentanyl strips now available for harm reduction. We have xylazine strips to look at if the drug they're using has a fentanyl or xylazine, so that we can prevent a death from that. These are the lethal doses of fentanyl, carfentanil, and heroin. If you look at the heroin on your left, the lethal dose of heroin is about 100 milligrams. The lethal dose for fentanyl is about 2 milligrams, and compared with the carfentanil, which is commonly used as anesthetic for elephants, it's a 2 micrograms is the lethal dose. A person can die with 2 micrograms of that. So this is how potent and deadly these drugs are. Moving on to alcohol. Alcohol kills more people than opioids. Just looking at the number of deaths of almost 500 deaths each day. Since this talk began, about 20 people, more than 20 people have died in the last 1 hour from alcohol use, alcohol-related use. And about 30 million Americans die from alcohol use every year. 30 million Americans have a diagnosis of alcohol use disorder, about 175,000 deaths every year. Out of those 175,000 deaths, about 120,000 are males, and the rest of them are females. And this is the standard drink defined by the National Institute of Alcohol Abuse and Alcoholism. About 54% of males and about 48% of females abuse alcohol. According to NIA, 4 or more drinks on any day or 8 or more drinks per week for women is considered as heavy drinking. See the difference between men. So men, 5 or more drinks on any day or 15 or more drinks per week is considered as heavy drinking. Why are women more vulnerable or more risk to effects of alcohol? There are 3 reasons. One is women have less alcohol, less water content in their body compared to men. And they also have more fat content. That alcohol is water soluble. It is not soluble in fat. So less water, more fat in women leads to increased intoxication from alcohol. So that's why even if the men and women drink the same amount of alcohol, women have more intoxicating effects from alcohol. And then the risk of breast cancer is high, a risk of heart disease, memory impairment, liver damage are comparatively relatively high in women compared to men because of this reason.
Srini, can I give you just 2 to 3 minutes?
Yes, sir. So this is alcohol-related
I've seen your
deaths.
slides, great slides coming in, but just take some, maybe the screening and stuff that you talk about. So
Yeah, just finished with the screening, sir. Just give me 3 minutes.
Yeah, no problem.
So this is the alcohol used during the pandemic. There are a lot of people that have, abused alcohol, have become abusers in alcohol use disorders during this time, during the pandemic, have a long-lasting effects from alcohol due to pandemic. But right now in 2022, the trends are going down compared with 2020 and 2021. So, like I said earlier, alcohol kills more people than opioids. Alcohol is abused by more people than opioids. More deaths from alcohol, more hospitalizations from alcohol, more emergency room visits from alcohol use. Moving on to screening, how to screen patients for people for substance use disorder, because if you don't ask them, no one will tell you that they are using drugs, right? No one will tell you that they're drinking alcohol. So it is essential, like we screen for depression in primary care settings now, it's essential to screen for substance abuse in primary care offices, pediatrician offices. So there are screeners that are available. You can use any of these screeners. Like, there are 2-question screeners for alcohol. There are 10-question screener for alcohol. There are 6 questions. I use CRAFT in my clinic. CRAFT is only 6 questions, which identifies substance abuse relatively easily. So these are some screening tools that were developed to different age groups. The questions are different for elementary school, middle school, and high school. These can be used easily. It takes a minute to ask this question. So do you have any friends who drank beer, wine, or any drink containing alcohol in the past year? So that's one simple question can give you what's going on in your child's life, right? And in a pediatrician's office, these two questions will give you, if the child is exposed to alcohol, are you actually drinking alcohol, or have friends that are, drinking alcohol. And then there are these questionnaires that are validated in different populations, like Kraft has 0.97 sensitivity in identifying all people that are using drugs that are diagnosed with substance use disorders. PESC also is another one that has high sensitivity, 0.97 sensitivity. And then NIAAA questionnaire with the two questions have a 0.87 sensitivity. So these are some questionnaires that you can be using in primary care offices to screen young children and teens. Okay, so this is again about Kraft, which is the one that I typically use in my clinic. This is a good tool to screen patients between ages of 12 to 21, and it is used as a universal screening tool. It has high sensitivity, like I said, 91% sensitivity, 93% specificity. These are the first three questions that asked about how many sips of beer or wine, how many drinks of alcohol in the past 12 months. It will quantify the number of days for alcohol, marijuana, or any other drugs, right? Three questions will quantify the use of the drugs. And then the next 6 questions will talk about if they have actually were in a car driven by someone with alcohol, that includes the parent or a friend. Have they ever used alcohol to relax or drugs to relax? Have they ever used drugs alone? Do you ever forget things while using alcohol or drugs? And if their family or friends tell you to cut down, and then have you ever gotten in trouble, like DUI? So those are 6 questions, and then based on the score, if the answer is 6 out of 6, there is a 100% risk of substance abuse, 100% diagnosed substance abuse disorder. If they have 3 questions, it's 79%. 4 is 92%. So once you do the brief questionnaire, I'm talking about this is done in a primary care offices, and you briefly review the 5 R's, review the results, recommend not to use riding and driving counseling, do not drive a car, even if it is driven by your family member that has alcohol in their system, right? And then see how they respond to that, and then reinforce. If they say like, I would never do that, then, then reinforce that with them after that. So the 5 R's, remember the 5 R's in brief counseling. And then, if there is a severe risk, obviously you refer them to a specialty clinic like ours. And then if there is a moderate to high risk, then brief treatment, just provide the 5 R's, the brief intervention, and then follow them closely. And then if they still have it, then refer them to a specialty clinic. And then the evidence-based treatments for substance abuse is still therapy, right? There is a psychosocial interventions. Well-established interventions are family-based therapies. You treat the individual, you treat the family with family therapy, and then also cognitive behavioral therapy. And then you have motivational interviewing. Motivational enhancement therapies are also efficacious, possibly efficacious 12-step programs, not for young kids. And then adjunct interventions include medications, pharmacotherapy, even also Dr. Baveja has mentioned about exercise, activity, increasing extracurricular activities, and then also setting goals, right? Having goals in life will actually help them. These are some treatments, and then we have evidence-based treatments that are limited, but they're available for teens and young adults for nicotine replacement therapy, bupropion for smoking cessation, buprenorphine plus naloxone for opioid use disorder, methadone and naltrexone as well, and then alcohol, naltrexone. And then there's one drug that I use in my clinic for marijuana, because there is no FDA approved medication for marijuana use disorder. I use NAC, which is N-acetylcysteine, 1200 milligrams twice a day will help. So this is a study that was done by my mentor, Dr. Kevin Gray in Charleston. So they looked at the NAC dosing in patients with marijuana use. NAC is 2.4 more times likely to have a negative urine compared with people that are not on NAC. So it's somewhat helpful for patients who are using marijuana. And then the same prevention strategies that Dr. Baweja has talked about, open communication between youth and the adults, education programs in schools and communities, involvement of extracurricular activities, and then strong bonding between the teen and the family always helps. Helicopter parenting helps here, right? I won't suggest for everything, but helicopter parenting is always helpful in this case, especially looking at the mom that actually caught a child getting dextromethorphan at 3 a.m. in the morning. She was surprised that her child was using drugs. This is a A student, is involved in a lot of activities, is a class leader, but still using drugs at night. So it can happen to anyone. So identify, be closely monitoring your children. And then finally, enhancing coping skills. These are some resources. If anyone wants, I can share these slides for resources where you can call to get this help. We talked about stigma. We talked about a lot of stigma around substance abuse, mental health. So addiction is a disease, just like diabetes, just like hypertension, and it's not a choice or a moral failing. So don't feel that you failed because your child is using drugs. Right? It's because of a lot of factors, risk factors we talked about leads to substance abuse. So stop judging and then see how you can help anyone that you know that has substance abuse, and then so that they can and do well in their life and succeed in their life. And again, thank you for the opportunity. This is my team at Six Bridges. If you have any questions, Dr. Wasser, it's over to you.
Okay, great. I'm so sorry I somehow lost the control of these things, but
No problem, no problem.
say that Srini is a dear friend and is a associate professor. I wrote the letter for him, so I know his credentials very well, and he came to my mind very quickly. I'm glad I brought him here. He's also going to be our board of trustees, so next time onwards you can complain about him. Not here, but somewhere. Anyway, and Raman, excellent presentation again. I learned a lot from this, both of you. And so we'll start the questions. I don't want to summarize or anything. Question was that, is there any reason why the suicide rate has gone up? Raman, can you take that?
Yeah, sure. Again, this is the multifactorial. It's not the easy answer. We have it. And this is overall mental health is going downhill. And plus now the changing cultural things in the form of now like the social media, for example, expectation. And I think this is all things are making things together. And the one thing I didn't share about that, the what lead to the completed suicide, I think easy accessibility for any mean, for example, if they have gun, for example, and that is a, if the gun is there, if somebody is struggling with the suicidal thoughts, so easy accessibility of the some means which can have the high impact. So all of these things are contributing to going up on the completed suicide and suicide attempt.
Okay. And there was another question about the akathisia versus anxiety. So as a clinician, I think, how would you recognize that? And sometimes we give antipsychotics medication to the children to.
So it's a very great question. And actually, this is all about the history. Like, in the psychiatry, many things we go by the history. Anxiety is the chronic pervasive condition. You have go to the history, you ask about, okay, tell me about how are you feeling this way? Like, is the restless is always restless? And what's underlying cognitions are there? They are worried about things, something is bad going to happen, or the panic attack versus akathisia. You start the antipsychotic medication. There is a temporal correlation is there when you start the medicine. Even when you ask the patient about that, tell me like why you are keep moving, and they will tell you, the akathisia patient, they tell you that, I feel I can't sit, I need to move, I keep moving. So there is exposure, which is here in the antipsychotic, new medication, you increase the dose, the akathisia start. And akathisia can also happen if you're on the continuing dose of that one. And then it's, but their anxiety, if anxiety is like, that is a different cognition there. Cognition means that how they present the symptoms, and they tell you like, I worry about everything when I try to do that one. And very commonly you can have that patient who have ongoing depression disorder, ongoing anxiety disorder, and then you add the antipsychotic, which is we do sometime, and then they present with that. Actually, in this is the abrupt presentation happen, akathisia. You can see that one like since last 2 days ago, 3 days ago, and then you cut down the dose, and you can as the benzodiazepine for short term. That is the different way of we manage that.
Great. Okay. I think I'm going to ask you one more. What do you think with the current government? Where is it going for pediatric healthcare? Are you worried? Are you excited about something good happening, like red dye going away or something? Or were there any strong data on the red dye? What do you think?
It is very tricky
Or the
question.
fluoride? If I don't know, you don't know much about fluoride.
Yeah,
You are-
again, there is a like as we this is a very things are going very politically. There are different ways going. I think many of our pediatricians are there. They are struggling more in that one. So again, there is a like good thing is there, like the food wise, for example, we need that like all the food addictive, or like adding the food stuff and the sugars and everything is, we our foods are so high calorie, high processed food are there. That is like, that's we all aware of that. But the mental health wise, now you're putting everything into that, the meds wise. And I think that is not very optimistic when we are not looking in the evidence what we have it like that. Any medication trial medication, it's go through the whole rigorous process there. And so that is very concerning about the red dye. And it is even one of the methods like they're like the sugar, if the kids take the sugar and they get more hyper in the night time. And so even the data is not to support that one, which I'm like, as per my knowledge, I don't know if Srinivasa, you know about any diet saying that it's lead to the behavioral symptoms or other stuff, that I'm not aware of that one.
Okay, great. I'm going to focus on a little bit on Srinivas. I think you focus on the drug use in India, but what about the other countries? Is USA using more drugs than other countries?
Yeah, so accessibility of drugs, Dr. Vasavada, is, they're more accessible here. If you look at the US, and there's a lot of drugs that come from neighboring countries. There's fentanyl coming from Canada. I think that was the reason that there were some issues early in this administration. They want to stop trade because of a lot of fentanyl coming from Canadian borders and then Mexican borders, a lot of drugs coming in. So anytime there is drugs coming from these borders, there is less production in the U.S., fentanyl production in the U.S., counterfeit pills in the U.S. Since we have more prescription drug monitoring programs across the country now, the prescription of opioids went down. That has led to looking for other drugs in the street, which includes fentanyl, which includes heroin. And then all the other xylazine is a drug that is never heard of, been used now as something to get high. So this is definitely a concern for all of us, because you never know what kids are getting into. It may just be a marijuana, but it has fentanyl in it. It may just be an alcohol that is laced with something that who knows the contents of what they're actually drinking. So I always advise my children not to even take anything from their friends, even if it's an open bottle, do not take it. If it's an open can, do not take it. The can should be open in front of you. So there is no risk with that. But that's all you can teach, right? We can't be there everywhere they go, but you just have to teach what we can with that. And then I saw the question in the chat about
go ahead. Yeah, if you see something, go ahead.
Yeah. Go ahead, Dr. Vasavada.
No, you go ahead. I think you have.
I saw there was a question about are there more substance abuse in the India than US? Here we have more identification process where we screen, we survey a lot of children, a lot of adults across the country. If we administer the similar surveys in India, we'll find more substance abuse. Alcohol use, we know every neighborhood has alcohol use problems. So more legal, more problem. I think marijuana is going to become the same as alcohol once it is legalized across the country. It
Yes.
will be the same issues that we see with alcohol now. More and more people die from using marijuana and also other drugs laced with marijuana.
Yeah, I think we are seeing a lot of CBD used even in 65, 75 years old for chronic pain issues. And that has caused psychosis. For me, it's the number one drug for psychosis now in my ER, beside
Yes, sir.
methamphetamine. And
Yeah, the other issue with that is, these states that are legalized marijuana, the kids are using parents' marijuana. If somebody has a marijuana in the house, which is a medical marijuana, that is what the kids are using. They're buying from those individuals that are getting those marijuana from the states, and they are using that marijuana or selling marijuana in the parking lots to younger kids. The
yes,
high school kids are making money selling those marijuana to younger kids,
I
and
think
they
that's
use
what
other
Dr.
drugs
Arora,
like opioids.
Dr. Arora mentioned that here. Um, is there any data on, like, like if I have a child and they get admitted to the hospital and they say, go to this fancy rehab. And so that is a question, one of the question, like, what do I expect? You think there is some recovery chances for my child, or is it just keep on going to rehab? And I see a lot of parents struggling with this also. And I just saw another guy who was a pro golfer, and he's still 41 and getting into car accident, killing somebody, and just a disaster for this really nice fellow. His life.
Yeah. So I mentioned about dopamine, right? Dopamine system learning substance abuse, and then you have hippocampus that learns from the use of drugs, the pleasurable effects. So let's say if I go to New York and then I go to a place, then it automatically triggers, if I drank alcohol there, it automatically triggers a craving for me to just go to that place, have a drink, right? And
Yeah.
then if I see a friend that we have a drink 10 years ago, if I see them again, I use alcohol with them, right? Anytime there is, we call it people, places, and things that are the triggers for substance abuse. Even if somebody has been sober for 10 years, 20 years, and if they are in a place where that there are cues or triggers for substance use, then they relapse, right? Relapse doesn't mean that that's the end of the road, right? You just like diabetes, right? The people with diabetes, they take insulin, and then that's when there is a mango season, you eat mangoes, right? Let's go to India. If we go to India, we eat mangoes. That doesn't mean that we relapsed, right? But it's just one bump in the road, and then you move on to long-term recovery. Even if there is one relapse, that doesn't mean they are going back into full addiction. So you keep trying, and then on an average, there was a study that looked at this. On an average, about 27 times. It takes about 27 times to get sober from alcohol, right? So 27 admissions, 27 treatments, whatever it is, that's an average number for someone to get sober from alcohol.
Okay, great presentation. Raman, you have to say anything for a minute, and then we can ask Amit to come back.
Yeah, just one thing. I think there's one question about SSRI, the family choosing the SSRI versus going for the psychotherapy. And there was also a question above that one. They were asking about they are looking for the psychiatrist and not able to find it. So what else we can do it? Unfortunately, this is again uh, patient. Sometimes the family, they just want to have the quick fix actually, and getting the medication at home versus committing for the psychotherapy, going every week, and having then also doing the proper CBT, like you have to do the homework. Patient, really there is a motivation, can be very challenging. So in that case is having doing like just explaining them, it is the psychotherapy is the long-term basis. For example, if you're treating the anxiety disorder, they need to learn the coping skill. Anxiety is always going to be somewhere, like, things will make you anxious about that one. So yeah, it is like educating the family, it's medication going to help you until you are taking it, not going to take away how you are coping with the stress and how you do that one. The second thing about, again, depending upon the where your situation, it is really problematic to find the psychiatrist most of our countries, actually, most of the part of our country. So in that situation, but I think the now 48 state have access child psychiatry access program. In Pennsylvania, it's called the TIPS, telephonic consultation program. I think that 48 states now we have it. So there is a state funded, or like now with the federal funding, that may be some little bit challenging. So there you can call and check with them. They can help you. They have the medication as well as they also help you with the care coordination. They can able
What is it called again? Can you slow down?
it's called the child psychiatry access program. That's the
Child Psychiatry Access Program.
so in like a different state have the different name. There you like
Got
for
it,
here I'm the
got it.
part of them. The PCP call me directly and I give them the medication. We have the care coordination team, so they help them to find the therapy services in the area. But it is state to state, and they may have not have it all the things. But that can be considered on the primary care level.
Can I add something, Dr. Vaswada?
Yeah, go ahead, go ahead.
So there is a program called HRSA, like HRSA funding for every state. So what they're doing is, if you go to a pediatrician and then you have expressed psychiatric issues, they have mental health support. In Arkansas, it's called RMAP, Arkansas Mental Health, in primary care initiative, where the pediatricians will reach out to psychiatrists in the neighboring county or other place, and then get a consult, it's a free consult to the pediatrician, and then they connect
Okay,
the
got it.
family for resources.
That's great. That's great.
And then one last thing. So I've been, one of the promises I made during my last 1 year was to start a mental health helpline for Indian Americans. Our population has been growing, every day. We have 5 million Indian Americans. Our people do not go to a psychiatrist that they don't know, a therapist that they don't know. They won't express anything, and stigma and then shame. So for that reason, just like 988 that exists for mental health, I want to set up something for Indian Americans, a call center that can be manned by a psychiatrist, a therapist, and anyone that volunteers on this, so that we can connect someone, like, let's say somebody calls from Pennsylvania, we can identify some resources for them, and then we actually directly talk to the psychiatrist in their community and then connect those people in that community. I do that all the time anyway, so I thought
we
this
all
would
do
be a
that.
good
Definitely, we all
resource.
do that. Yes, yes.
I think,
But,
with Amit's help, we can launch that pretty soon.
Yeah, please involve IAPA too, and I will help you to get linked with them too. So
Yes, sir.
program, really. I mean, I cannot find better speakers than that, and it's well done here. There are some questions. Raman, you want to quickly answer the one that you said I will answer? I think it's about HIPAA violation for 18 years and over, or so. Is that what you were talking about? Is Raman still there?
The one question I saw above, and that I answer. I don't know.
You answered. Okay, good. Okay, Amitji, are you still here?
Yes, I am. I for some reason I cannot.
Yeah, me too. I could not figure it out, Amit. I'm so sorry.
No, that's okay. So I can. I don't know whether you can see my video. Thank you so much. It was a great talk. I mean, great start to the CAB program. Keep it up. And we had amazing speakers. I learned a lot about child psychiatrists, which I may not be able to use. But bottom line is that this is something which is more of a general knowledge, and that's what we've tried to do. We tried to do in this year's CME. I told Tarak, who is the CME chair, to make topics which are interesting and more of a general topic rather than a specialty specific topic, so that way people can all join in. So hopefully this thing will take effect next month onwards, and we'll have one particular day, and we'll let you know way in advance, and we'll try to get you topics which are which are interesting to every specialty, not just the specialty which you're speaking on. For example, I can give you an example on urology, for example. Overactive bladder, everybody sees that. So that's a good topic which everybody covers that. Even a psychiatrist sometimes sees overactive bladder secondary to some drugs. And so that's one kind of topic. So I'm just giving an example, and cannot have asked for a better start. This was such an interesting topic and also interesting discussion. So please keep it up, Tarak. Well done. And the opening batsman did great. Thank you so much, Dr. Baweja, Dr. Gokarkanda. Like stars as usual. Thank you so much. And anyone who has registered in this conference, anyone who has registered will get a link to answer a couple of questions, and you'll get your CME credit right away. But one of the things which I'm going to ask, we may not be able to do it this time, so we'll let it slide this time. But next time onwards, only API members will get the CME credit. So please become an API member, $100 lifetime membership. It just shows your commitment that you want to be a part of our API while we are trying to steer API into safe waters. We need your help and we need your support. Really, really, it's a big support which we're looking forward and hoping that you can help us navigate these stormy waters and get back to safe havens. And if you guys have any specific questions, feel free to send it to Tarak, and he will guide it to the specific speakers, and they can answer later on. So thank you again, everyone. And Tarak, you can have a couple of last words, and we can stop today.
I think I'll probably say that this was great. I think, like Amit said, it costs money for everything. Amit and API had to get contract with the CME companies. They charge money. So if you become a member, it pays for that. And if we don't charge you anything as a member of API, which is like, who gives you 50 CMEs free with $100 life membership? It's worth it. It's worth investment for years to come. So please become a member if you're not. At least ask your other family members, your children who are becoming doctors now, to become a member. Srini, there is a question that is about video thing. If you're still there, can you answer that?
I'm here.
So video addiction, anything on that?
Yeah, so social media and gambling has now been designated as addictive disorders. So just like, there are rehabs in China that actually target social media and internet addictions. We are yet to see that in the US for treating those disorders, but we treat just like any substance use disorder. We treat that as same as any other substance abuse. So internet addiction, gambling, same thing as alcohol or marijuana use disorders.
I mean, it's just like the addiction with the screen time. So
yeah, same thing.
Screen time could be that. This one also. I think this also gives you some rush. Same way the screen time gives you rush too. So
yeah, the dopamine surge is the same, right? The more you do, and then I've heard about TikTok disorder tics. Dr. Baweja, I can tell more about that. There is established evidence that watching TikTok can increase the risk of tics or increase the incidence of tics. So there is a lot to study in that area.
I never knew that. That's amazing. Well, I think we ought to call it a night someday. So this is a night. Good night. And I cannot believe how good it went. And Dr. Baweja and Dr. Srini both are excellent presentations. And hope we can bring you back at even national meeting and you take part in various API activities to help us educate and teach.
Sure,
Thank you.
So
Thank
can
you
you
all
put
the
your
audience.
can you put your email in the chat? Somebody's asking your email.
I did several times. Is there?
Oh, okay.
At vasavada.us is there.
Yeah, okay.
If you are in some of the WhatsApp group, you'll find me. Amit has my email. So again, I'd like to thank the audience because we are like 70 people at the end. It's dwindling down, but I cannot believe it's 9 o'clock here in Central. It's 10 o'clock in the Eastern, and you guys have to go to work tomorrow. I know it's Friday, but still have to work. So I really thank you, and I'm excited to be your CME chair, and we'll do better and better every time. and I'll be
Thank you.
prompt and responsible for what we do here. Thank you, everybody.
Thank you, sir.
Thank
Good
you.
Thank
day.
you all.
Thank you all.